Okay, so I'm going to start with the nursing care with complications of pregnancy that we've started in Chapter 5, but I'm going to jump ahead to where we were since we've already talked about all of this. Let's see here. We got through a lot of it, actually. Here we go. I'll start here with gestational hypertension, okay? Sorry, let me get my notes going over here. Okay, gestational hypertension. So gestational hypertension, we already discussed some of this, but I'm just going to start from the beginning because I think it's easier to start from the beginning. See Table 5.5 on page 90, hypertensive disorders of the pregnancy. Gestational hypertension is a blood pressure greater than 140/90 after 20 weeks of gestation. It does not include proteinuria. The blood pressure then returns to normal by 6 weeks postpartum. Now remember, there is no treatment. There is no cure for gestational hypertension. The only cure for gestational hypertension is delivery of the fetus, which sometimes means we have to do preterm delivery in order to get the mother's blood pressure down. Okay. Preeclampsia, that's one of the manifestations of gestational hypertension that has kidney involvement. So that's the blood pressure 190/40 after 20 weeks gestation with renal involvement. So you will have proteinuria. Renal vascular changes resulting in decreased renal blood flow causes the proteinuria. Central nervous system changes with headache, visual disturbances, and hyperreflexia, and some hepatic changes with epigastric pain. Then we're going to run into eclampsia, which is another manifestation of gestational hypertension. And what happens is preeclampsia then progresses into eclampsia, which involves the central nervous system causing seizures. You have liver and coagulation abnormalities present, and it can lead to pulmonary edema, acute renal failure, abruptio placentae, and maternal death. It can also lead to HELLP syndrome and DIC, which we talked a bit about. So HELLP syndrome again was hemolysis, elevated liver enzymes, and low platelets. Thrombocytopenia, abnormal bleeding, clotting. We talked about what we might see in this patient. Be sure that you see home care on page 92 for gestational hypertension management. The patient must have phone access, transportation to the hospital. We must advise that they stop smoking and alcohol use. They have to have daily blood pressures. They need to monitor fetal kick counts, have a balanced diet with protein, bed rest possibly, reducing the stress and sensory stimulation, daily weights, checking the DTRs, that's deep tendon reflexes, which we talked about in class, and clonus, which we talked about in class, and seizure precautions possibly. Medication for gestational hypertension would include magnesium sulfate. That's the main medication that patients get with gestational hypertension. What it does is it is a CNS depressant to prevent the seizures. So it doesn't really do anything for the blood pressure itself, but what the magnesium sulfate does is depress the central nervous system to prevent the seizures. All right, the method of action, the MOA, is that it relaxes skeletal muscles via direct action on the central nervous system, raises the seizure threshold. The route is given IV via infusion pump. It's very strictly monitored. It's very painful. If anyone's ever had magnesium sulfate, I did have to get magnesium sulfate when I was pregnant with the twins. It's also used because it is, the method of action is the fact that it relaxes skeletal muscles. It can be used frequently for preterm labor. So I got magnesium sulfate when I went into preterm labor at one of the many times with the twins, and it's not a pleasant drug. It makes you feel like crap, and it burns really bad going in. It can cause a lot of issues with the veins, if you're not monitoring it closely, and the fact that the route or the dose needs to be monitored closely. The antidote for for magnesium sulfate is calcium gluconate, which will be given IV push. You have to have that on hand. If you have magnesium sulfate going, you have to have calcium gluconate on hand. Signs and symptoms of toxicity with magnesium sulfate would be if the patient has absent DTR, so absent deep tendon reflexes. You do the reflexes and nothing happens. They have no knee reflex, no knee jerk, no nothing. Respiratory rate less than 12 per minute, a urinary output less than 30 milliliters per hour. Okay, you have to watch that with these patients. All right, gestational diabetes. Gestational diabetes mellitus. Oftentimes we just call it gestational diabetes. Glucose intolerance with the onset during pregnancy. It returns to normal by 6 weeks postpartum. Be sure that you review page 97. Box 5.4 tells more about it. The stress of the pregnancy puts strain on the pancreas. It cannot keep up with the insulin demands. The signs and symptoms, which you would notice, is glycosuria. If you don't know what that is, be sure you look it up. All right, diagnosis is at 24 to 28 weeks per GTT, a glucose tolerance test, which we've already discussed. I can't even remember if that was earlier this week or last week. No, it had to be this week. So glucose tolerance testing, that's where you drink the orange solution or you eat a whole bunch of jelly beans, real sugary jelly beans, and then you have your blood drawn. So they do a 1 hour GTT and a 3 hour GTT. If the 1 hour is elevated, then they have to do further monitoring and do a 3 hour GTT. The treatment is a low carb diet, finger sticks frequently, insulin, exercise, NSTs, and kick counts. If you do not remember what NSTs and kick counts are, look through your notes. You guys have to understand this stuff. Okay. 35 to 50% of women with gestational diabetes will develop type 2 diabetes later in life. Infants born to moms with gestational diabetes, I hope that you'll take time to pause this video and look it up in your book and see what happens to infants that are born to moms with gestational diabetes. I'm going to go ahead and tell you that they are going to be large for gestational age. They're called LGA, large for gestational age. That means it's a very large baby. It's called fetal macrosomia. The baby is large, fetal macrosomia. Immediately after delivery, infants born to moms with gestational diabetes will often be seen with hypoglycemia, respiratory distress, and injury from the macrosomia, from the fact that they are so large. They will have injury during labor. Often it's a broken clavicle. All right, if you have questions about that stuff, you guys have got to email me, okay? Anemias, iron deficiency, and folic acid deficiency anemia. Sorry, I got laundry going. Oh, I skipped a page somewhere in here. Oh, let's see. Here it is. Sorry. Whew. Iron deficiency anemia. It's difficult for women to get all the iron from their diet alone. Therefore, they need to get some supplements. They almost always have iron supplements during pregnancy and especially postpartum because they've had some blood loss. We always give them iron supplements. They need iron related to the increased blood volume, the transfer of blood to the fetus, and the expected blood loss during delivery. Now, hopefully you guys remember from first semester probably that vitamin C enhances the absorption of iron. If you don't remember that, something you guys need to go back and review because that's one of those basic things that I would be shocked if it wasn't on boards on NCLEX because that's just kind of a thing that they expect everybody to know. All right. You want to take iron with vitamin C, but what do you not want to take iron with? Hopefully you guys know that you don't want to take iron with milk or antacids. All right, folic acid anemia. Causes are anticonvulsant medications, oral contraceptives, sulfa drugs, and alcohol. They'll take folic acid supplements. Effects on the fetus, if they have folic acid anemia, is, if the mom has folic acid anemia, is neural tube defects. They're encouraged to start folic acid during the childbearing age before conception even, and we talked about this, I think, maybe the very first week. So be sure you see page 103 for nutrition considerations. That's when we discussed that earlier, the folic acid and iron, actually. All right, infections. Torch infections. I call them torch infections. T stands for toxoplasmosis. O stands for other. R stands for rubella. C is for cytomegalovirus. H is for herpes simplex. So toxoplasmosis, if you don't know these, look them up. How do you get toxoplasmosis? Okay, hopefully you guys have heard rumors or people talking that they don't want you changing the cat's litter box while you're pregnant. One of the reasons is because of toxoplasmosis. It can sometimes lead to serious eye and brain damage in the infant if the mom's pregnant. Then O is for other infections. R is for rubella, which has serious fetal effects. You can see that on page 104 in your book. Cytomegalovirus, CMV. The mom is asymptomatic. She doesn't even know she's got it, but it can be fatal to the baby. Again, that's on page 104. And then herpes simplex, type 1 and type 2, can lead to fetal death. If active lesions, what type of delivery is needed? So if the mom has active herpes lesions, vaginal lesions, if she delivers vaginally and has active lesions, and she delivers the baby vaginally, that transfers to the fetus, and it can lead to fetal death. Therefore, if the mom has active herpes lesions, she has to have a C-section. Okay, now she can have a history of herpes and not have any active lesions and have a vaginal delivery. But if she has any active lesions at all, or they're concerned that for any reason, they will go ahead and do a C-section for her. Okay. All right, group beta strep. GBS. This is a big one that you'll hear people talk about frequently. Group beta strep is a normal flora. It's a normal bacteria for many women. The woman is asymptomatic. She does not have an infection when you have group beta strep. Because it is a normal flora, you do not have an infection if you are positive for GBS, if you're GBS positive. However, it can affect the fetus during labor and birth, the birthing process, and it can infect the fetus, and therefore treatment has to be done. So let me see, that's on the other side. So let me start with over here. It can be fatal to the newborn, just like the herpes simplex virus. Screening is done at 36 to 37 weeks gestation, and the way it's done, right over here, diagnosis, is from vaginal and rectal swabs done at 36 to 37 weeks gestation. Okay. The treatment is antibiotic during labor. Usually it's penicillin, preferably a minimum of 4 hours before delivery, 1 to 2 doses. So if the mom comes in, she's 37 weeks, and she's delivering, and she's done her GBS test and it's come back positive, she is not necessarily infected per se. She doesn't have an infection, but we have to treat her so that the baby is safe. So she will need to get IV penicillin, preferably, depending on how long, we're going to start it as soon as she starts laboring, and then she may get a couple of doses of it. She needs to get at least 1 dose. All right, the fetal effects, what can happen to the baby if the mom delivers without being treated. Pneumonia, sepsis, respiratory distress, apnea, and meningitis. Okay? So it can be fatal for the newborn. All right, substance abuse. Substance abuse includes illegal drugs, tobacco, and alcohol. The fetus is at the greatest risk in the first trimester, but still serious effects throughout the entire pregnancy. I think that was a test question, maybe, about teratogens, when our teratogens have the greatest effect, and it is during the first trimester, which, if you guys don't remember what that's called, look back through your notes to remember what you would call that stage. All right, be sure you look at table 5.9 on page 109. It covers alcohol, cocaine, marijuana, tobacco, anticonvulsants, ACE inhibitors. Right now we're seeing a lot of heroin. Okay, you would be surprised. I know people, when I do this lecture in person and students say, how are you going to know if the mom's doing drugs? They'll usually tell you. If you ask non-confrontationally, if you just ask, I need to know everything that you're taking because I need to do what's best for the baby, and knowing what drugs you're using helps us to better prepare to take care of the baby after the baby's delivered, and that type of thing, they will tell you. They'll tell you what they've been using. If you are not non-judgmental, they will let you know. Okay. So that's another, we want to be non-judgmental to patients regardless, but part of that is if you can develop that trusting relationship, whether you agree with it or not. I mean, obviously I don't agree with patients using cocaine or heroin during pregnancy, but I need to present it non-judgmentally so that they can talk to me. They feel that they can open up and they can have a conversation, and we can find out the whole story instead of just bits and pieces of the story. Okay? All right. So there wasn't too much left of that. That covers the rest of that chapter. And I think there's something posted maybe on group beta strep, GBS, and several videos that are posted online. Be sure that you review those. Be sure you've looked over all of these notes. This is a lot of information. This chapter is kind of a lot of memorization. And application, because you have to understand, you have to memorize the process or memorize the tests or memorize the complications, and then you have to apply them to a situation that I give you. So remember the exam will be Monday at 8 o'clock. Be sure and bring your laptop if you're testing on the laptop. And then we will lecture after, so be sure you bring your notes because we're going to go ahead and start lecturing. All right, let me know if you have any questions.